Drugs like azacitidine or decitabine, the so-called hypomethylating agents in myeloid malignancies such as myelodysplastic syndrome and acute myeloid leukemia, are considered as standard for higher risk myelodysplastic syndrome and for patients with acute myeloid leukemia who decline intensive chemotherapy. They can bring about response rates of approximately 35 to 40% in these populations, but the responses aren't durable. While certainly some studies have shown response durations and overall survival that can crest a year and a half, in population-based studies, in truth, the overall survival is closer to about 7 or 8 months. Pevonedistat is referred to as a netylation 8 inhibitor. What it does is in inhibiting netylation 8, which is an enzyme in the cell, it leads to blocking of DNA replication, cell cycle inhibition, and NF-kappa B signaling, ultimately leading to a cell's apoptosis and eventual death. The study that we conducted was a phase 2 study of pevonedistat combined with azacitidine versus azacitidine monotherapy in patients with higher risk myelodysplastic syndromes, chronic myelomonocytic leukemia, or acute myeloid leukemia. We randomized 120 patients in a one-to-one fashion to both of those approaches. There were approximately 67 patients who had higher risk MDS who were randomized, 17 patients who had chronic myelomonocytic leukemia, and 36 patients who had acute myeloid leukemia. Those patients were then followed over time with a primary endpoint of event-free survival. Interestingly, from a safety perspective, we didn't detect any distinguishable higher rates of toxicities to the combination of drugs compared to what we would have seen with azacitidine monotherapy. This includes what I would have thought would have been obvious increased rates of adverse events such as fever and neutropenia or other types of infections. When we focused on event-free survival for the entire population, it was superior for the combination of pevonedistat and azacitidine at 21 months versus 16.6 months for azacitidine with a trend toward significance. The study wasn't powered for overall survival, but there was a numerically higher overall survival median for the combination at 22 months versus 19 months for azacitidine. When we drilled down to the higher risk MDS population, the event-free survival actually was significantly prolonged for the combination of azacitidine and pevonedistat at 20 months versus about 15 months for azacitidine. Overall survival, once again, was numerically superior with an advantage of about 5 months for pevonedistat and azacitidine with a median of about 2 years compared to 19 months for azacitidine alone. When we focus on the low blast AML population, the oligoblastic AML population, the overall survival once again was numerically superior at almost 24 months for pevonedistat and azacitidine. Compare that to only 16 months for patients who received azacitidine monotherapy with a trend toward significance. The next step for this drug is to conduct a randomized phase 3 international study in patients with higher risk MDS of the combination of pevonedistat and azacitidine versus azacitidine alone, this time focusing on overall survival.